Rovaroxaban for thromboprophylaxis in high-risk ambulatory patients with cancer. Definition: patients with active cancer at increased risk of venous thromboembolies. The current score identifies patients with cancer at elevated risk to VTE who could benefit from thromboprophylaxis. Rivaroxaban therapy results in significantly lower rate of venous thromboembolies than the placebo among interviewed high-risk ambulatory patients with cancer who were studying chemotherapy. The insight of major bleeding was low. Video.
Venous thromboembolism is a common complication of cancer. While subcutaneous low molecular weight heparin is the standard treatment for cancer-associated venous thromboembolism, the role of direct oral anticoagulants is unclear. A randomized open-label non-inferiority study of 1,046 patients with cancer and confirmed venous thromboembolism tested the efficacy of anticoagulant therapy for up to 12 months. One group was treated with subcutaneous low molecular weight heparin for at least 5 days, followed by 60 milligrams of oral edoxaban once daily. The other group received 200 IU of subcutaneous dalteparin per kilogram once daily for 1 month, followed by 150 IU per kilogram thereafter. The primary outcome, a composite of recurrent venous thromboembolism or major bleeding event during the 12-month follow-up, occurred in 12.8% of the patients receiving edoxaban, as compared with 13.5% of the patients receiving dalteparin. Statistically, this result demonstrated the non-inferiority of edoxaban to dalteparin, but did not demonstrate its superiority. Recurrent venous thromboembolism occurred in 7.9% of the patients receiving edoxaban, as compared with 11.3% of those receiving dalteparin, and major bleeding occurred in 6.9% of the patients receiving edoxaban, as compared with 4.0% of those receiving dalteparin. The authors conclude that in patients with cancer and venous thromboembolism, oral edoxaban was non-inferior to subcutaneous dalteparin for preventing the composite outcome of recurrent venous thromboembolism or major bleeding. Edoxaban's lower rate of recurrent thromboembolism was offset by an increased risk of major bleeding. Full trial results are available at nejm.org.
Application in nursing. A study have been carried out the acid prevent started with the aim of finding a cost-effective prophylaxis method not only from the economic point of view, but also in relation to the hemorrhagic risk. The profit margin is very variable if the consider of the procoagulant and primary elements change in the evaluation of the patient. Video.
Welcome to Impact Factor, your weekly dose of commentary on a new medical study. I'm Perry Wilson. This week, 2 studies, both alike in dignity, in the New England Journal, where we lay our scene. Yes, we're going to examine the Cassini and Avert trials, both of which evaluated whether oral anticoagulants would prevent venous thrombosis in high-risk patients with cancer. And I'm excited to talk about these studies because they lay bare a central intuition of clinical trial design that I don't think is necessarily true. But let's start at the beginning. Individuals with cancer are at increased risk of developing blood clots, but prevention requires the use of blood-thinning medications, which themselves carry substantial risk. Physicians and patients are not always great at balancing risks and benefits, so it would really help if we had strong data to guide us. We had a bit. Prior to the recent publications, 2 large randomized trials had examined the use of low molecular weight heparin in ambulatory patients with cancer and found a significant reduction in the risk of clot from about 4% to 2%, meaning you'd have to treat 50 people with low molecular weight heparin to prevent 1 clot. For a high-risk drug, that felt like a lot. To prevent 1 clot, we're essentially treating 49 people unnecessarily. Moreover, neither study showed a difference in overall mortality, so practice wasn't really changed. Enter a bit of intuition that I will argue is wrong. It goes like this. Imagine a population of individuals, all of whom have different baseline risk of developing a blood clot. Instead of enrolling this diverse group in your trial,
Pros and cons. Pros. Rovaroxaban is used to treat deep vein thromboembolies, are usually in the leg, and pulmonary embolies. It works by decreasing the ability of blood to clot. It is also used to prevent stroke or serious blood clots in people who have atrial fibrillation. It is administered in daily close lower rate of blending. Cons. Single high risk of gastrointestinal blending than warfarin. Blending from the gums, intensive menstrual bleeding, weakness, fatigue, headache. Video.
Thrombosis is the formation or presence of a blood clot within the circulatory system. Blood clotting can be useful as it prevents excessive blood loss when a blood vessel is injured, but clots can also form when they aren't needed and cause serious medical problems. Let's look at 3 such problems. In deep vein thrombosis, a clot forms in the calf or thigh as a result of stasis or slow blood flow. For example, in people who experience long periods of inactivity, or in response to inflammatory mediators from surgery, trauma, or infections. The clot can cause pain and swelling. If part of the clot breaks off into the bloodstream, it can end up lodging in the lungs. This is called a pulmonary embolism and can be life-threatening. In individuals with atherosclerosis, a blood clot can form within an artery supplying blood to the heart muscle in association with an atherosclerotic plaque. The obstruction to blood flow can result in a myocardial infarction or a heart attack. In patients with atrial fibrillation, the most common form of cardiac arrhythmia, a clot can form as a result of the ineffectual contraction of the left atrium. If the blood clot leaves the heart and travels through the circulatory system to the brain, a stroke can occur.
Issues in Ecuador. Remember that 1 in 5 patients with venous thromboembolic decide as cancer, and 1 in 10 20 patients with cancer will develop a BTA. Video.
Prophylaxis after venous thromboembolism after total hip or total knee arthroplasty has been found to reduce morbidity and mortality. Extended duration of postoperative prophylaxis has shown additional benefit, particularly in patients undergoing total hip arthroplasty. In this multi-center double-blind randomized controlled trial involving 3,424 patients undergoing total hip or total knee arthroplasty, patients received 10 milligrams of Rovaroxaban once daily for 5 days postoperatively, and then were randomly assigned to continue Rovaroxaban or to switch to 81 milligrams of aspirin daily. Prophylaxis was continued for an additional 9 days after knee arthroplasty and 30 days after hip arthroplasty. During 90-day follow-up, the rate of symptomatic venous thromboembolism was 0.64% among patients in the aspirin group, as compared with 0.70% in the Rovaroxaban group. There were 8 major bleeding events among the patients in the aspirin group, and 5 major bleeding events among those in the Rovaroxaban group. Similarly, there was no significant difference in clinically important bleeding in patients receiving aspirin as compared with Rovaroxaban. The authors conclude that aspirin is not significantly different from the direct oral anticoagulant Rovaroxaban for the prevention of symptomatic venous thromboembolism after total hip or total knee arthroplasty after an initial 5-day course of Rovaroxaban. Full trial results are available at nejm.org.
Conclusion. In my personal point of view, primary thromboprophylaxis with Rovaroxaban significantly reduced the incidence of symptomatic VTE in outpatients with cancer. To treat with chemotherapy, further steroids are needed to assess the effect of the prophylaxis on mortality and the cost of care of patients with cancer. Video.
Prophylaxis after venous thromboembolism after total hip or total knee arthroplasty has been found to reduce morbidity and mortality. Extended duration of postoperative prophylaxis has shown additional benefit, particularly in patients undergoing total hip arthroplasty. In this multi-center double-blind randomized controlled trial involving 3,424 patients undergoing total hip or total knee arthroplasty, patients received 10 milligrams of Rovaroxaban once daily for 5 days postoperatively, and then were randomly assigned to continue Rovaroxaban or to switch to 81 milligrams of aspirin daily. Prophylaxis was continued for an additional 9 days after knee arthroplasty and 30 days after hip arthroplasty. During 90-day follow-up, the rate of symptomatic venous thromboembolism was 0.64% among patients in the aspirin group, as compared with 0.70% in the Rovaroxaban group.